Right, we'll start back again. So, our next speaker is actually Dr. John Coulter, and he's going to do a very interactive session. He wants plenty of opportunity for you to engage with John. That's going to lead us up into the actual official Q&A. So, if you haven't got, if you have your questions, that's your time to ask questions of John and Seamus. And again, if you want to pop them into the box, and we'll take them out of that if you don't feel comfortable enough to ask them in front of the audience. Just one thing when it comes to asking the questions and so on, and you'll notice we have a camera here. The camera is for recording the speakers, so as we can put those speeches and stuff onto the website. We won't be recording you asking your questions and so on. So rest assured that when you go to ask your questions, that none of that stuff is actually recorded. So in terms of introducing John, John's a practicing gynaecological oncologist at the CUMH. After general training in obstetrics and gynecology from 93 to 98 in both Cork and the Coombe Women's and Infants University Hospital in Dublin, he travelled to Australia and completed a 3-year Ranscog fellowship training scheme. He is currently a consultant in Cork and is chairman of the Cork Gynaecological Oncology Group multidisciplinary team. They do this to me every single time. They put in very, very big words all close together, and I'm supposed to get it, and usually I do, but this one has challenged me a tad. He's also a member of the National Cancer Control Programme Guideline Committee on Hereditary Gynaecological Cancers. And I suppose, like Seamus, he's a really good supporter of OvaCare, and I would like you to give him a warm welcome here today. So, John, over to you.
Well, while Seamus was getting an email from a patient, I was getting a text from Angelina Jolie, no less. Or I thought I was. I got a call from News Talk last Tuesday week when Angelina's story broke in the news at lunchtime, asking me would I go on with George Hook in the afternoon. And as you mentioned, as the gynaecological lead in the National Guideline Group for Hereditary Gynaecological Cancers. And they asked me would I come into the studio in Upper Lane at 5:30, and I said, not a hope. I've got a huge oncology clinic. Last week was Patrick's Day. Not a hope, I'm sorry. Would you do a telephone interview with him? And I said, okay. What does he want to ask me? We haven't a clue. So I did a telephone interview with him at 3:30 for about 10 minutes. And it went out at about 5:30. I was still in the clinic. I got a text from talking about teamwork, got a text from one of my colleagues, sounding great. And I texted back, thanks Dan, is it okay? So then he rang me. And I said, hi Dan, how are you going? He said, how are you talking to me? Aren't you in the interview? And I said, no, that's recorded. And I said, so why are you ringing me? I just wanted to hear your phone ring during the interview. So then 2 hours later, I get a text from the American cell phone number. Hi, Dr. Coulter, this is Angelina. Would you mind if I give you a call for some advice? And then I get a text from the same number. Hi, this is Hello Magazine. Are you free for a photo shoot? I then realised this is one of the lads, one of our team again, had gone to the trouble of phoning one of their mates in the States to text me as Angelina. So there you go. What I decided to do today, rather than have more science about what we do surgically, etc., because we've discussed that before, and I've discussed why we operate in the way we do and why we pull back and why we do more, I think it would be a nice blend for the meeting to have a lot of science and interactivity. So what I discussed with Rachel was that we would maybe have an interactive session that I would go through what I think are probably important side effects or complications or the most frequently questions I'm asked by my patients in the months and years following surgery for ovarian cancer. I don't think there's much point in talking about the acute hospital stay and the surgery itself and the week around the surgery itself unless someone wants to ask me anything about that. I thought I'd go through the months that follow surgery and the common things that I think happen, and as always the interactivity gives us new ideas as to what are probably more important to you than what we consider are probably more important to you. So I thought I'd just go through some of the short-term effects that we discuss commonly at post-op visits, etc., the more long-term effects, and what I would consider to be very personal effects for each woman. And that can have huge individuality, and I'll discuss how I approach those particular personal effects. So let's and of course, please stop me and put up your hand if you want to ask a question as I'm going through these things, because this is the interactivity that I think we should have. Of course, we'll have an opportunity to discuss them when we sit down for half an hour at the end of this talk. But please make it as interactive as you want. Okay, common things are common. Of course, there's a big wound. Very often it's below the belly button. Sometimes it's all the way up to the breastbone, depending on what we need to do surgically. We use epidurals a lot now, since I moved from the South Infirmary in 2013, having spent 10 years there, to CUMH, which are a fantastic innovation for all of our patients now undergoing acute surgery. But when one goes home, and even though there will be pain relief, etc., the pain and the discomfort from the wound can go on. It takes about 6 to 8 weeks for the wound to get even just a half of its strength back, which is why we tend to tell people be careful for about 4 to 6 weeks. Not that you're going to burst everything open, but you could do a little bit of damage underneath the skin in the muscle layer, which makes you at risk of a hernia later on. So it's not just discomfort at what you're doing, but you've got to protect the wound for later on, because the risk of a wound hernia later on is about maybe 3 to 5%, especially if you consider that someone having surgery for ovarian cancer already is unwell and behind the game. Protein levels in the blood are down, you've got a chronic debilitating illness that has been there for maybe a year or more that you haven't even known about. So coming into surgery, you're not as well as if you're coming in just for an elective hernia repair or an elective appendectomy or elective anything. Okay? So that's important. But when women go home, they often complain of discomfort or pain for quite a while, and that is normal. It can be normal for quite a while. It can be normal for 3 months, 4 months. But my friend was flying after a month, and she went on holidays. Why am I not flying after a month? Everyone is different. What we do inside the wound is extensive. So it's not unusual for someone to complain of persistent pelvic pain, maybe on one side or the other. And I'll often explain something like, well, look, that's where this mass was really stuck in your pelvis, and this is where we had to, for the want of a better word, dig this out surgically. So there's a lot of healing going on in there, which is going to take a while. And of course, your body's immune system mops up all of the dead cells or all of the healing cells. There is a pattern of inflammation, not infection, but inflammation in the tummy when everything is healing, and that can last for quite a while. So just because there's persistent pain on one side of the pelvis or the other does not mean that the cells are back. It means that this is just part of the healing process for quite a while. Your bowels can do anything. I'm sure a lot of you know that. Your bowel habit from what it was before can be completely different forevermore. And that's not necessarily related to chemotherapy, nor the chemotherapy drugs that help reduce the risk of nausea and vomiting, etc. Surgery alone can have a profound effect on the bowel because we're operating ill the pelvis. And the nerves that stimulate the bowel to keep everything moving along are in our surgical field. So very often, somebody who had a normal bowel habit before and now has terrible trouble a few months later, usually constipation rather than the opposite. Very common for the bowels. We say they slow down, and they can slow down for months. And we do need to use bowel stimulants, etc. People use prune juice or whatever, and they may work, but they may not work. One may need more than that. But it's not uncommon, and it's quite normal for anything. Anything goes with regard to the bowels. But usually in time, they will regulate themselves, and it may be completely different to what one was like beforehand, but that doesn't matter. Everyone complains of tiredness. When is this tiredness going to go? And I'll say, you've had a huge operation. The operations tend not to get much bigger than what we do in the abdomen especially. Okay? Thankfully, we only have to operate on the bowel in about 3% of patients. Okay, so we can avoid that. But if you consider again the amount of healing that's going on for a number of months afterwards, even though you look fine and you feel okay, but you just can't get rid of this tiredness, it does take a while. I had my chest opened twice by one of the surgeons in the Mercy when I was a 21-year-old med student in third med, playing international tennis at the time, and it took me 4 months as such a fit young man to get anywhere near what I thought was normality again. So if that is the case in someone like me at that age, you've got to expect that this is going to take a while. It does get better, and of course there are complicating factors, like you may be going on to chemotherapy straight after your surgery, or within weeks of your surgery, or within 2 months of your surgery. And of course that's going to have a profound effect as well. But surgery alone will make you very tired. Your body has to heal everything that we've done. It's basically our fault. Okay? So I'm always saying to women, don't beat yourself up about the fact that you're not walking your 10 miles 2 months or 3 months out like you were beforehand. It does take a while. And as I said, of course, chemotherapy or radiotherapy can add to that. Okay? These are very common things that very often, even at the 6-week visit or the 10-week visit after surgery, these would be some of the commonest things that we would discuss. And they're all quite normal. Menopausal symptoms, especially in those women who are premenopausal having their surgery, if they have menopausal symptoms, it is my fault. Okay, because I have surgically removed the ovaries. And in rare circumstances, we are lucky if we can diagnose an ovarian cancer located in one ovary in a young woman with the uterus and the other ovary normal and all the lymph nodes and everything else normal, and we may get away without chemotherapy. And we can do fertility sparing surgery. But usually, as a lot of you will know, unfortunately, it's a later stage when the cancer is diagnosed, and in younger women, we have no option surgically but to remove the uterus, tubes, ovaries, etc. So menopause is a surgical menopause caused by us. I suppose with our oncology hat and blinkers on, our job is to try to cure this cancer. Other things, as I mentioned before, are optional extras, unfortunately. Fertility, ovarian hormones, I suppose, are optional extras to us whose job it is to try to cure this. So is there a problem with dealing with this? The answer is no, there isn't from our point of view. A lot of the old textbooks say gynecological cancers, especially endometrial cancer, are contraindications to hormone replacement therapy in whatever form, be it natural, over the counter, or in a health food store, or anything that contains a little bit of natural estrogen, or formal HRT taken by tablet or patch or gel or whatever. From our point of view, there is no contraindication. It does not increase the risk of it coming back. Now, women who've had breast cancers and now have an ovarian cancer or vice versa, that is a different group, of course. And I know the breast cancer surgeons will be very slow to let women have HRT. That might be changing a little bit in the literature, but we can use local estrogen in the form of estrogen pessaries like Vagifem in women who have had breast cancer, who need something over 3 or 4 weeks to improve symptoms in the lower genital tract area. But in general, we don't have a problem with women using hormone replacement therapy. So just because I've taken the ovaries out and there has been ovarian cancer, does that mean the HRT is contraindicated? No. Does it mean that natural compounds are contraindicated? No. And even in women who were postmenopausal already, and maybe are at the age of 60 having surgery, and we take out the ovaries and all that kind of stuff, sometimes those women can get some menopausal symptoms back, and you kind of go, how the hell does that happen? Well, what happens is those ovaries are still producing, even though they're postmenopausal, are probably still producing tiny little bits of estrogen. You don't know it, and you don't notice it because you thought you went through menopause before, but a number of women have said to me, I've got my flushes back. How the hell did that happen? It can happen. Okay, because there is a little bit left in the ovary, and now we've surgically removed it rather than biochemically what happened maybe 10 years previously. So that's not unusual either, and we don't have a problem with anyone who wants to use whatever they want to use. Longer term effects, as I said, there's a big overlap between the short term effects and the longer term effects. The bowel can go on doing its own thing for years afterwards. Okay, may never settle down to what it was, and we deal with that as it happens. It may be an issue, it may not be an issue. Tiredness, once again, overlap. How long is a piece of string? We don't know. I've had women 18 months out saying they're still very, very tired. Of course, sometimes we will reinvestigate to see, is there something else going on? Are they anemic? Do they have thyroid-related problems? Is there another reason for their tiredness, like anybody else who might go to their GP who hasn't had an ovarian cancer, may go to their GP talking about tiredness, and there are a battery of tests that can be done to see, is there something else going on? Appetite is another thing. this now isn't related to women having chemotherapy, because we all know what can happen to appetite. But later on, in 6 months to years out, appetite might be completely different. Now, we know that in women who have very poor appetite leading up to surgery, very often that is the bulk of the disease in the upper abdomen. And that is improved usually greatly by removing that bulky disease. But the other thing is that the ovarian cancer cells, the way they spread along surfaces, they can actually affect the nerves, as I said, that allow the bowel to keep going. And if the bowel slows down a bit, your appetite isn't going to be as good. You get full a lot more easily. So anything can happen appetite afterwards, and it's not really a big problem. It is not unusual for it to happen. Something more personal. And you might look at the sentence, and this is not an offer to anybody. But I personally, as many of you might know, and others, do not have any issues about discussing intimacy with patients. One of the reasons I suppose I can personally talk about it is that as part of my training in Australia, they took it incredibly seriously. That we often operate and give chemotherapy and radiotherapy to patients, and if we have a good cure rate, what's left? The fallout is that their personal relationships might suffer with their partners. Even though they may be cured of the cancer, this is the fallout at the end. And when I did my gynaecology exit exam after 3 years training, they took it so seriously that of the 10 stations we had in the exam over 3 hours, one of those stations was purely on a psychosexual question. It was an actor. She was a 25-year-old blonde, gorgeous Australian woman, and one of the gynaecologists was playing her husband with his arm around her. And the whole station was about her having had chemoradiation for cervical cancer, and even though she was cured, their intimacy was the big problem, and the whole question in the exam was about that. So I was lucky in that and of course the Australians were very much in your face anyway about asking about these things. And when I came home to Cork and started discussing these things openly in the clinic, I'm sure the nurses were thinking, in the name of God, what have we brought back from Australia? But the more we spoke to patients, the more people felt that they could open up to us, because they knew that we were comfortable talking about these things. And I know a lot of you will know our clinical nurse specialists who are very good at discussing these, and even Vicky Cleary has done a PhD on these kind of issues. But I personally know that this is a very important issue to a lot of women. And this is not necessarily psychosexual issues with regard to vagina and vulva, etc. Even the fact that there's an abdominal scar can be a perception to a woman that, her body image is totally different, and is someone going to have trouble with intimacy with me because of this awful looking scar, just because it looks awful, whatever. Even these small things may be very important. So when we discuss things, we shouldn't have, and I'm not afraid to ask if anyone wants to discuss any of this. And usually I'll get an idea by throwing out maybe a small, little, simple but disguised question, and I'll get an idea very quickly whether this is a goer or not, whether anyone wants to go there and discuss these things or not, rather than the fear of something, sure, I couldn't ask him that, or I couldn't ask them that, or they're too busy. That's the other thing, they're too busy. Look at all the women sitting out in the room, they're too busy. If ever someone comes in and they're late, they're 2 hours later than they should be coming in to me, I'll say, look, I'm terribly sorry, I needed to give someone else some time. And I think a lot of people will understand, well, that could be me, I could be the one that needed that time. So intimacy matters, I think, are very important, because we understand that there are a lot of physical and psychological changes that can occur. And this can be the fallout of surgery. There isn't a huge fallout from ovarian cancer surgery with regard to the lower genital tract. That's obvious. But even doing a hysterectomy as part of the surgery removes the cervix. And the cervix and the ligaments leading to the cervix contain a lot of nerves which are very important with regard to sexual satisfaction and orgasm. So we know that as well. So even though we haven't operated on the lower genital tract, there are still a lot of reasons why people may have difficulty and their perception of their new physical nature after the surgery and the role it plays in intimacy. So that's something that I feel is very relevant to discussions as well. And of course, the perennial question, after all is said and done, what people want to know is, will I be okay? What's going to happen? you know, and that's where I think one is in a cocoon with us for the first X number of months. There's big surgery, there's chemotherapy, either chemotherapy first and then surgery. And it's all very, very, very tied in and seeing us very regularly, etc. And then when things are over, that's where you're let go on the boat, on your own, out into the ocean. And the question is, what's going to happen? Okay, I'm going to be coming back to see them in 3 months' time. What's happening over that 3 months? I had all of this team around me for 3 months. What's going to happen now? Will I be okay? And that's where one of the CA125 issues, people live and die by their CA125s every 3 months or every 6 months. And we all, you know, we could come out into the waiting rooms and see this kind of, you know, waiting what CA125 was or what's he going to find, you know, and that's a great unknown, you know, and we're in a very privileged position. We know that. What is our examination going to find? And I think it's very important that we're all, if I find that everything is normal, I'll say, your examination is absolutely normal, you're doing great, things are great. Will I still be okay? Of course we don't know, but the longer you go out after your surgery and your treatment, the less the risk of it coming back. We know that. So this is a very important question, will I be okay? Because when all is said and done, when we talk about the complications and side effects of everything we do, this I know very much is the question everyone has at the end. Now, that's a presentation I threw up, just to give you an idea of what I think are probably the important things or the relevant things with regard to the outcomes after surgery and the potential side effects and the fallout after ovarian cancer surgery. If any of you want to ask or comment, please do.
Just regarding the fertility space
Yes.
that you were talking about.
Yeah.
Just for young woman, how do you decide for that? Is to do with stage, with grade? Let's see if it's early stage, stage
Yeah.
1.
Yeah.
If the grade is high or if
Yeah.
they're on the
Yeah. Thankfully, that is an easy question to answer. The question was, how do we decide on how to do fertility sparing surgery on or not? The group who will get away without chemotherapy that we can spare fertility is the group who've got a cancer that is confined to one ovary. That is early grade 1 usually, grade 1 or grade 2. In other words, the cancer cells don't look aggressive. Now, how can I tell that this cancer is confined to that ovary? I can't by the naked eye, because 30% of those women will have microscopic spread elsewhere in the tummy. Okay, so if I just assume it's confined there and don't give her chemotherapy, I'm going to be wrong 30% of the time. So what we do surgically is we remove the lymph nodes, the omentum, and do peritoneal biopsies. And if they're all negative, because these are the sites that these cells usually go to, if they're all negative, then now we can truly say pathologically this is confined to that ovary. It's a grade 1. She does not require chemotherapy. And we've had a number of those young women who've got on and had children that we've done that fertility sparing surgery to. If the lymph nodes or the omentum comes back showing, there's microscopic disease, it has spread already, she will need chemotherapy. Now, chemotherapy doesn't necessarily mean that she will become infertile. But usually if it's spread, we tend to do more extensive surgery, because if it's gone there microscopically, how do we know that we're not leaving microscopic disease in the other ovary? And of course, as Seamus showed the slide, the better we do surgically, if we can get rid of all of these cells that we can see, the better the result. So in general, we do a full staging surgery without taking the uterus and the other ovary.
Does mean you only actually give fertility sparing surgery for a young woman who don't need chemotherapy?
We can still give chemotherapy to someone who's got it confined to the ovary if necessary. But if the rest of the staging is negative, there's a little bit of small print there, but in general, no, somebody can have fertility sparing surgery and chemotherapy.
Like if there is a positive cells in the washing.
Yeah. If positive cells in the washing, this is spread beyond the ovary. And the problem is, if you're leaving the uterus and the other ovary behind, it's possible that there's disease in there as well. Now, one of the other small print things is that sometimes these ovarian type cancers have actually started in the uterus. You can get a serous papillary cancer of the uterus that spreads like ovarian cancer, which is why we tend most of the time to take the uterus as well, because on occasions with different histological types, we'll find that there's a cancer in the uterus as well. So we've got to be very selective in who we perform fertility sparing surgery on.
If you say the CA125 is kind of gone,
Yeah.
is there anything to replace it? Is there scans or anything that can be done?
Oh, look, not currently, because, I mean, the one great problem with CA125 is that it is not specific to the ovary. And as we know, just because it goes up does not necessarily mean that the cells are back. Once again, putting our oncology hat on, what you're trying to do is individualize treatment to somebody that you think is going to make a difference. Okay? So if you don't have any symptoms and our clinical examination is normal, we tend to say, look, we don't need to do any scans. You must remember, every CT scan is about 400 X-rays at least of radiation. I was a referee recently for one of the research programs for a big €100,000 grant in UCC, and one of those studies that did very well on that was actually a study by the radiology department trying to reduce the radiation exposure in patients with Crohn's disease who are having CTs all the time, because they know that that number of scans can cause secondary cancers. So we tend not to use CTs and ultrasounds unless they're really going to change our management. If you have a symptom that we can't explain, or we can find something on examination, then we'll do a scan to see what's going on where. Because if I find something at the top of the vaginal vault clinically on examination, I'd say, I think there's a recurrence here. My first question is, where else is it? I'm not going to assume it's just there. So then we'll do a CT. Or if you've got back pain for the last 4 weeks, it's not getting better and kind of coming out around the side or whatever, and we can't find anything in clinical examination, then we'll do a scan. But in general, we tend not to, because at the end of the day, based on the CA125 trial that Seamus O'Reilly was talking about, we know at the end of the day that the end result 5 and 10 years out may not be very different whether we find something on scan immediately or in a month's time or something like that. You would have thought that getting rid of or throwing chemotherapy or something, or surgery at something while it's tiny, might make a difference. That's not necessarily always the case. So in general, we do scans when we should, not because we can. But CA125 was fraught with difficulties, And even as a well woman test that GPs will do, I'm forever saying to GPs, please do not throw a random CA125 in as a well woman test when you're going for a mammogram, smear, etc., because it's fraught with difficulties. You've got to see it. Like we would consider 35 as normal, right? Upper limit of normal, and you've got someone who's got a 70, and then you're kind of wondering, what the hell do we do? And their ultrasound is normal, so the ovaries look normal, but it's still 70, etc., etc. Now, of course, on rare occasions, you're going to have someone with a random CA125 that's up, and they do have something. Now, that is fortuitous, very fortuitous. But in general, it creates more trouble than it's worth. At the moment, we don't have anything else, to answer your question, to be a good specific test for ovary. Oh, sorry.
Sorry, Doctor.
Yeah.
I speak? My name is Mary McGrath, and I was diagnosed with primary peritoneal cancer in 2011. And the only reason my situation was found is that my GP did a CA125. I'd never heard of this before. My count was at 8,000
Mm-hmm.
when I was, and I know that it's below 42 is a normal
Yeah.
level. And as my chemotherapy progressed, it came down and down and down.
Yeah.
But my last CA125 was in 2012, and I haven't had any since.
Mm.
When I ask about it, I'm told you will get anxious, and we don't really need unless you have no symptoms. But my anxiety comes from, I don't know if this disease is back at all, and because it doesn't show tumours, even the CT scan, what does it show you? It's not it's in my peritoneum.
Mm.
And so there are no tumours to see in there. So that is I'm following on.
Yeah, I mean, that's why I made it. When I saw your hand going up, I thought to myself, and I just said that CA125s don't actually help and they can be more harm than good. And I saw your hand going up and I'll say, I'll bet you this is somebody who had a fortuitous CA125 done that showed 8,000. Of course, we're going to go, okay, there's something going on here. Okay? So you are one of very, very few, and all of the others who are well, but overwhelming, the radiology department, the hospitals, the outpatients, etc., where we find nothing abnormal, is one of the issues. This goes back, I suppose, to the trial that Dr. Riley was talking about, about the CA125s and the value of CA125s and how important it is, or does it make a difference at the end of the day? There's a lot more small print in that the further you can go without second or third line chemotherapy, perhaps the better the chance it'll work when you finally need it. So it's not all about necessarily getting in straight away and using all the aces up your sleeve when there's just a rising CA125 but nothing abnormal to find on scan. CT scans are very sensitive for picking up disease. Primary peritoneal and ovarian cancers are extremely similar because when the ovary grows, when we're all tiny little babies in mom's womb, our ovaries grow down from the back, come down into the pelvis, and they have a covering, a little plastic covering on them. And it's that covering which is the peritoneum. They have a little envelope of peritoneum around them, and that's what becomes malignant in ovarian cancer. So the primary peritoneal and the ovarian cancers are the same, more or less. CT scans may be wonderfully read by those experienced, like our gynae radiologists, Joe Barry and Max Ryan, are superb. They will find things on CTs that others won't. CTs in the right hands can be extremely sensitive and very good at picking up recurrences of primary peritoneal and ovarian cancers. So they are very sensitive for what's going on in the tummy, read by the right people, which is why when we have scans sent from anywhere else in the country, we always get a disc, upload them onto our system and get our guys to look at them. Because they'll say, that's an overcall. That is not a recurrence. We're not worried about that. Or, we have found a few spots that they didn't. So you do need to do some training. And that's the great value of our multidisciplinary team meeting every Monday morning, where we look at everyone and we discuss everyone individually as to what is the best thing for them,
And that's, I'm just laughing because that's very reassuring for everybody in this area, but I'm from the Dublin area, so I'll be asking them to recheck the scans up there for me. But I just wanted to go back to you talking about HRT. It's just that I was obviously diagnosed with ovarian cancer back in 2011, and I was 39 and went into post-surgery menopause. But HRT was never on the table for me.
As in, you were never offered it, or or did you ask about it?
Never spoken to about it. Just assumed it was an estrogen-related thing because it was an ovary.
Yeah.
And I assumed that, obviously not my team, but I'm just very interested because for the last 4 years, obviously, I've been going through the menopause and I'm wondering, could that have been alleviated in some way? I really assumed HRT was not the go.
Of course, this now is where I bag one of my consultant colleagues up in Dublin, and look, from our point of view, there is good evidence in the literature that of all the gynae cancers, endometrial cancer would be considered probably to be the one most hormone sensitive. Now, not dependent, but sensitive. In other words, estrogen should never be given to someone with an endometrial cancer. Not true. Why would you deny someone who's got a very aggressive endometrial cancer hormone replacement therapy when their worst symptoms, despite their treatment, the living every day with menopausal symptoms is the worst thing that's happening to them at the moment, when it's not going to influence whether it comes back or not? And similarly, the very non-aggressive cancers have such a low risk in endometrial cancer of coming back that giving HRT does not worsen that risk. And that's in the more hormone-sensitive cancer, endometrial cancer. In ovarian cancer, and some of the ovarian cancers are like endometrial cancer, the endometrioid pathology type. There is no evidence in the literature that it increases your risk of it coming back, in the absence of breast cancer, etc., in the past, etc. So all I can say is that it's something that I know is very relevant, but that may have been my Australian training. You know, I mean, to be perfectly honest, things are improving, but when we were training in obstetrics and gynecology in medical school, a lot of these things were not part of our training at all. It was all didactic science, you know. But when you broaden your horizons and you train as a gynaecologist, you suddenly realize that surgery is a very important role of your being, but a very important role you have is communication and alleviating the side effects and complications of what we do, because that's the fallout. And this is the fallout, and all I can say is from my point of view, you and I would probably have had this discussion a long time ago, because I'm not sure if you brought it up yourself or you felt that you weren't allowed to bring it up. And I don't know who you've seen or who your gynaecologist has been, but
brought up, I assumed
yeah.
it wasn't there.
Sure, yeah.
You know, if somebody doesn't talk to you about options,
Yeah.
well then how do you know you have them?
Yeah, I mean, I think there are two important things with regard to what you've just said. Number one, I suppose everyone's different. My training is different to somebody else's training, maybe elsewhere in the world. Personalities are different. A lot of people that I know in the room, you know, I would hope that I can talk very easily to, and they feel they can talk very easily to me about anything. Other consultants and other doctors are different. They may be incredibly clever, but not great communicators, etc. And secondly, I think, and very importantly, I think the role of our clinical nurse specialists is just, has revolutionised our lives completely, and I think revolutionised your lives as well. You know, and I know for a fact that I'm sure our two gynae-oncology liaison nurses would have brought this up ages ago as well. So even though I'm kind of standing here saying, you know, of course we would have discussed this if you were here. I mean, I can't speak for everybody else, but from my point of view, certainly it wouldn't have been an issue. You know, and I'm sorry it didn't come up. You know, because you could have.
I'm not blaming my team or anything.
Sure.
It's a great team.
Yeah,
It's
yeah.
just when you started talking about it, I was like, when I saw it up there, I thought you were saying no, it's a no-go. Then people
No,
saying,
the
"Oh,
opposite.
yeah."
The opposite.
So I was
Yeah.
just surprised.
The opposite. Yeah.
Can I ask you one more question?
Of course.
Sorry.
Yeah. If that's. Yeah.
Just about the BRCA gene, would you recommend that people go for that testing if they have been diagnosed with ovarian cancer?
That's a hard one. I'll tell you why it's a hard one, because you've got to consider the fallout of the result.
Well, can
Right.
I ask why, if we already have cancer, what is the fallout as a result of that?
Oh, sorry. I thought you were talking about women in general.
No,
Okay,
I mean,
sure.
I mean,
Yeah. Okay, I suppose two things, and anybody else who wants to comment, of course. With regard to the economics of doing it, okay, I know the genetics team in Crumlin, like everybody else in the HSC, are going to be strapped for the funding they have to do whatever they can do. So, of course, they're going to put criteria in place to try to maximise the positive results. In other words, when I say positive, as in maximise the number that they diagnose appropriately having BRCA1 or BRCA2. So they've got to put roles in place that they say, look, we will get maximal return for the funding we have by focusing on this group. Okay? There is now emerging evidence, we know, that those with a high-grade serous papillary carcinoma have a much higher risk of having a BRCA1 or 2 genetic mutation. I was in Australia in November at the International Gynae Cancer Society, and one of the papers presented showed that more than a third of women with high-grade serous papillary type cancer will quite possibly have a BRCA1 or 2 mutation. So we discussed, was it last year, I think, or the year before, that this was the big elephant in the room, right? That this was something we wanted broadened out, you know, to try to make sense of a lot of what we're doing, because there are a lot of other people at risk that don't even know it, number one. George Hook said to me, he asked me a question, why the hell would you operate on someone who doesn't have a disease? Right? Talking about the Angelina Jolie thing, and I kind of thought, you just don't get it. You know? Surely prophylaxis is going to be better than everything everyone has to go through. You know? For a laparoscopic procedure, you know, day case, in and out, to take out ovaries, etc., you know. So we know that this is going to explode in terms of us trying to generate what we get the HSE to allow us to do. I mean, we've set up a new the first in the country, I think, pure Gynaecological Hereditary Cancer Clinic in CUMH. Noreen Russell, who is our most recent appointee, has set up a new clinic just for those with hereditary risk. You know, because it is so important, and we're getting more and more every week. And the issue with regard to Crumlin is trying to get into the system and get it done. Or secondly, there's no reason why one couldn't go away and have it done themselves. But the fallout I talk about is the fallout with regard to one's personally, about knowing about breast cancer risk, insurance, mortgages, etc., but the family also.
Yeah.
Do you share? Do you have to share your knowledge with the others? Do they want to know? I have one family, 3 different sisters, 3 different decisions based on the gene mutations. You know, one didn't want testing. I don't want to know. One, the testing was positive, wants surveillance, doesn't want surgery. And one opted for surgery immediately. 3 different sisters, and what did the other one say? Was what I was getting, and I said, look, that is not appropriate for me to comment. You know, you're each individual patients of mine. These are confidential discussions. You need to ask X, Y, or Z, you know. But there's no reason why one couldn't go off and have it oneself, and I think, you know, it's becoming a bit more and more available. But we do know that we need to, and will be hopefully in the future, testing more. But the problem is, unless funding is generated for Crumlin, for Andrew Green and his team, you know, it's going to be just difficult to get into the system. I don't know if you want to comment. Yeah.
I think this remains a big elephant in the room. We're very concerned clinically that there are patients that should get tested that aren't being tested. Welcome to Cork, because if you're in Cork, there's an 18-month waiting list for when we send out the paperwork to Crumlin. 18-month waiting list for people, and often you're talking about risk reduction surgery decisions, family concerns. We're terrified when we see people that they're going to develop a cancer while they're waiting to be tested, and while they're waiting then go on another waiting list for risk reduction surgery. The complexities of it mean that you can't really just go or, you know, send off the blood test because you need the genetic counselling, you need the support afterwards, and we find that at times when we've had patients where where they're in the terminal phase of the illness, we've had to do the test and send it off, and then the family meet the genetics people after the patient has died, and it's very unsatisfactory, and you feel that you're very concerned that things could, a bit like what the Queen said, things could have been done better or not at all, or they could have been definitely done better, that it would be more timely if people had more of an opportunity to contribute. And then the other aspect, so I think this is the concern that you're missing people that could be cured with screening and risk reduction surgery. And then the second aspect is that, with the PARP inhibitors for biliary serous cancers, these are drugs approved by the European agencies that will increase survival in this group. But if we can't identify who benefit, then we can't give the drug. And if we can't genetic test, we can't give the drug. It's a waste. It's a waste of the patient's time. It's a waste of healthcare resources. Unfortunately, it doesn't seem. I won't mention the word, but I won't mention my favourite topic. But at the time when there was money in the country before it left to pay the bondholders, the genetic service did not develop to the extent that it developed. That it exploded globally, or in parallel with other services. In 1998, there were 3 medical oncologists in the country. Now there are 40, and the cancer genetics did not grow to the same extent in parallel to meet with the advances in advances that are occurring. And I guess when you see people, I mean, you're very young, and I think when we see people who are young, oftentimes they're not concerned about themselves; they're concerned about the children. And this is part of the jigsaw of cancer care, And
just initially, when I asked about it, I was kind of batted away and told, "Oh, you already have cancer, so it's not going to help you in any way." But I persisted over the last couple of years, and I'm going for genetic testing next Wednesday. But since then, I started talking to my family, and on my father's side of the family, there's loads of ovarian cancer from sisters who died, but they died in the 50s and 60s. Where nobody actually spoke about genetic cancers or gynecological cancer, so breast cancer, ovarian cancer. The men, my dad didn't know because his sister didn't tell him.
Yeah.
And I just persisted, but like my cousins and all are getting tested I'd known that ran through my family, my father's family, I didn't know what ovarian cancer was when I was diagnosed. And I'm not a stupid person, I'm well educated. I was kind of going, what? I expected it to be cervical, breast, the other cancers, but ovarian, I was like, can't get
See, a third of mutations are new, so there won't be that. Family size is getting smaller, and families can be estranged, so you won't pick up that. Plus, a family history has to start somewhere, and we often find that you meet someone the first time, but after 4 or 5 years, then a pattern you can see a pattern starting to develop in the family where testing was not appropriate 5 years ago, but is appropriate now. I was at a breast cancer meeting recently, and I met a guy from Beirut, and he was presenting on genetic testing in the Middle East. Now, Lebanon, if I've ever visited, has no postcodes at all. There's no postal system there. They brought in the Canadians because they've destroyed the place so much. So that's the infrastructure they're dealing with. But he couldn't believe that a patient in the developed world would have to wait 18 months to see a genetic counselor. He just shook his head, and it's very hard to justify. But I think Henry Lynch, who we mentioned on the slides, he came to Ireland to give a talk, and he said, ask, because if you ask, you will screen, and if you screen and if you ask, you will test, and if you do both of things, these things will save lives. And I think that's the biggest issue with all of this, that you can save lives. And I guess a bit like the fuck it thing. The other big fuck it is where you could have done something, where something could have been prevented by more lateral thinking at the time and wasn't.
When we're taking histories from patients, one of the most important questions we'll ask is there a family history of this? Now, I mean, someone coming in with an ovarian mass on a scan, okay, I still don't know whether this is ovarian cancer yet or not, so I'm not going to just jump out and say, do you have any other family history of cancers? What do you mean? Why are you asking me that? So I'll usually kind of say something like, do you have any significant family history of heart attacks, strokes, cancers, is the way I'll say it. So that someone doesn't think, what does he know that I don't yet, even though I might be suspicious. Because very often when you get a family history, we're starting to plot in our minds already what we may or may not need to do for this woman. If she's got an ovarian cyst that's 7 centimetres in size, looks very benign on scan, and I'm not worried about it, but she's got a family history that I ask her about, I might be more likely to say, I think I should probably take that out, rather than rescanning her in 6 months' time that I might do with somebody else. You know what I mean? So it's very much in our minds to get a family history, but to word it in a way that you're not going to cause somebody fear or anxiety as to why you're asking, even before you operate it on, and because it might change what we do. But we're very much in tune. I mean, once again, with our gynaecology multidisciplinary team, the Monday mornings meetings we have are great because you've got a lot of important, intelligent minds around the table, and someone will come out with something, and they're always up to date with the literature and the most recent research studies. So you're really getting the benefit of a lot of people's brains around that table, and somebody sometimes will come out with something that you didn't think of. That'll stimulate you to think of something like family history or something else in the individual history.
I could just ask you, I had the genetic testing and I don't carry the gene, but it was recommended by the girl from Crumlin that my 2 girls had their ovaries removed by 40.
Okay, I don't know why or what the circumstances were behind that, but I mean...
It's the only way of reassuring because you can't test for it.
Sure, well, I mean, look, one of the things they might have been getting at, the fact is that they test for what they currently know. Things might be different in 5 years' time. We might find out that they found what we call the founder mutations, are the genes we know are most importantly mutated at the moment. They may be only part of the story. This is like cervical cancer and HPV. The HPV vaccine that all my daughter and the others are getting, and the boys in Australia are getting. We always thought 16 and 18 were the important ones. We now know 31, 33, 35, 47, 52. So this may happen to be our CA in the future. So it may be that they're saying, look, we haven't found a gene mutation. However, there may be something else going on and it may be recommended. But then again, look, I can't comment on that because I don't know what the individual situation is. But in general, we're not recommending that, family members of somebody who may not have genetic family history at all. We're not advocating that they have surgery. I mean, you've got a lifetime risk of about 1 in 70 without a family history. That goes up to about 3.3% if you have a first degree relative with ovarian cancer, and it goes up to about over 7% if you have 2 relatives with ovarian cancer. Okay? That's still less than your lifetime risk as a normal woman with no history of getting breast cancer. So you've got to be careful and playing the odds a bit. So just because you might have somebody in the family with an ovarian cancer without a significant family history or gene mutation doesn't mean you have to have your ovaries removed by the age of 40, with fertility and menopausal symptoms, etc. So, we often say to patients, we'll operate on you if we should, not because we can. So you've got to individualise it. Sorry.
Okay, just not to disturb the flow, but Seamus is actually on call at 12:30. So if anybody has a question for Seamus before he goes, he'll take the question. Otherwise, he'll step away on call, and we'll keep going with the Q&A with John. So anyone got a question for Seamus?
Thanks, Seamus.
Specifically for Seamus.
Great job, John.
Specifically for Seamus, on one question, please.
So just I know that we've seen that's
Yes.
I know it's the hardest one to actually for pathology report to be diagnosed now.
Yes.
Is it the CA 19.9? Is it? And the CA are they any good?
So
Is it CA 125?
So the ovarian cancer is a family of cancers.
Yeah.
Like the endometrial cancer that we talked about in the HRT issue, and there's clear cell and serous biliary. But the mucinous tumours we tend to think it's coming from somewhere else, potentially from the bowel or the pancreas, and so the marker pattern may be different for those. So there's an evolution now to treating them more like a gastrointestinal tumour, and to look for another source for them.
No, it was actually in our case. It was proven that it was actually primary. It was
Okay.
because the stains there,
Mhm.
the CK7.
Okay.
So it was there, but the grade was never mentioned on the pathology report. And I know it's an expensive one or an athletic one.
Yes.
So my daughter has fertility space surgery.
Okay.
And I presume it was an expensive road because it was just a question. I never asked the
So I think
gynecologist.
when we see them now, we make sure that there's not something somewhere else. There's not coming from the gastrointestinal tract. I think that would be important. That it is. It obviously is, as you say. If we give chemotherapy, we tend to give more of a chemotherapy geared towards gastrointestinal tumours rather than ovarian tumours, or at least consider them as part of the treatment plan.
So the CA 19.9
Can be helpful. Yeah.
That would be helpful.
Yeah.
Okay. Is that it
Another
for
question
Seamus?
back- there was another question back there.
No, sorry. I had it in the box. If I remember what I tried to remember what I was asking you was, you had the chart up there about the survival rates, and I know that the 60 months that's used is based on previous records and things like that. I just want the survival rate. Does it reduce even with Avastin? Does it reduce drastically according to the number of recurrences that are there?
I think you get less benefit with each time, yes, because the tumour evolves.
So instead of worrying about 60, which is a number I hate now, instead of being 63 this year, I'm going to be 21 3 times.
So Seamus, thanks very much.
I think the 60 is also because that's a time point where a lot of the trials and registry data complete at. But say in breast cancer, it's 10 years, 5 years. They don't talk about 5 years anymore. We talk about 10 years. And 10 is becoming more important than 5 now because treatments are getting better. So to see a benefit with treatment, you want to see it beyond, a benefit beyond, which is a good thing. Which is a very good thing. But 5 is a very historical thing because a lot of the follow-up on clinical trials will stop, goes say up to 5 years, and then the funding will stop. So for the studies that you see, it's 5 years because that's when they've decided that. But it's also a practical thing. They have to have a deadline at some stage, and there's often institutional funding.
Okay. Okay, Seamus, thanks very much. And John, you're still on. Just, if I can, some of them are in the actual the question box. start with one here, John.
Yeah, okay.
What are the survival rates for stage 4 ovarian cancer after 5 years? Previous treatment, chemo plus surgery.
On average, about 25 to 30%. On average. I always tend to be a very positive kind of person. And I always tend to say to women that I'm looking after, you know what, if you read the internet and you look at 5-year survival rates and you say, oh my good God, you know, I turn it on its head and I say, well, why can't you be the one? Because what we're looking at is we're looking at a group of 1,000 women in a research trial, okay, and say maybe 250 to 300 of them are alive and well after 5 or 10 years' time. Do we know who those 250 or 300 are going to be at the start of that? We don't. There are certain indicators that may give you an idea that such and such a person has a better chance of being in that group, but we are never, ever as surprised as we are with women we thought would do brilliantly, with no residual tumour after the surgery and should have a very good response to chemotherapy and should do brilliantly, but come back 6 months later with a recurrence and you kind of go, where the hell did that come from? Or women that I open up and it's just as if somebody poured glue in, and I've used that analogy before, and you just kind of go, I'm going to cause mayhem to the bowel and everything if I try to do what I can do in here. So let's give chemotherapy first and then come back and do surgery, and you kind of go, this is not a good prognosis. And then 10 years time, they're coming into you saying, how are you going? You're kind of going, how did that happen? You know, so there's so much more to it than surgery and chemotherapy. I think we're kind of the tip of the iceberg. I think someone's immune system, which you can't scientifically validate, is incredibly important. You know, all of the studies showing, you know, a few extra months of a survival rate based on a certain different way of giving the drugs, that's fine, but I mean, I think your immune system does a lot to actually kill these cells as well, which is why I always try to be quite positive with people and say, look, why can't you be the 1 in 3 or the 1 in 2 who are alive and well in 10 years' time? Because even though I can't give you a research tool that will validate this, I think someone's attitude to what's happening is incredibly important. Which is, now that he's left the room, which is why I often say to patients, be careful when you go to the radiation and medical oncologists, because they tend to be glass half empty people. In other words, anything else is a bonus. And I've said this to Seamus, and I've said this to Jennifer Gilmore and the others, so I mean, look, we laugh and joke about it. Now, it might be just my personality, but whatever, but I think it's very, very important to have an attitude that, you know, that's going to try to improve your immune system and get things going as best as possible. Now, that might be gobbledygook, I don't know. But I certainly believe it. I can't prove it, but I certainly believe it.
Why is it that when you're going through treatment here, that the oncologist would not allow you to take vitamins or minerals or anything like that? Whereas I've a cousin in America who went through the same treatment for ovarian cancer as I did last year, and the first thing they gave her was vitamins and minerals before they came into it. And she came out of it twice as well as I did.
Yeah, sure. Look, I don't know who's refused anyone vitamins, minerals or whatever. I don't know, and I don't want to know who said that. But I mean, from my point of view, look, I'm not giving the drugs. I'm doing the surgery. But I'll say to anyone, look, as long as it doesn't interfere with what we think we're trying to do as what we think is the best thing for you, then go ahead and do whatever you want. I mean, we're very blinkered. Like, our medical education is incredibly scientific, and it's very poor for seeing the wood from the trees, to be perfectly honest. The way we were taught was just didactic, scientific thought. I remember somebody coming in talking about acupuncture in the Coombe Hospital for obstetric patients and gynaecological patients. And some of my bosses there, like, she ran out in tears because they were so blinkered. They thought this was useless because she couldn't prove with prospective randomized trial data that this worked. Because she couldn't prove that, it was poo-pooed, you know? So I don't know why somebody would have said that, but I mean, you would have thought that vitamins or tonics or whatever may help someone psychologically to get through what they're getting through. That doesn't impact on the use of the chemotherapy drugs or whatever. I would have thought that there shouldn't be any problem. I mean, you know, when you're going through treatment and trying to live as normal a life as possible, I would have thought that anything that can help that. You know, I have no right to say you can't use that, so I can't explain that, but I don't have an issue with anything like that. I mean, all we can tell is what we know or think is the right thing to be doing for you. And if you've got certain things interfering with that, then all we can say is, look, this is what we think is the best thing to do. I wouldn't take that because there is evidence, but if there's no evidence, I remember in Australia, a 26-year-old that we had with recurrent ovarian cancer, and she was, I think, on her third line chemotherapy, and obviously, as Seamus had said, I suppose the chances of things working, you start with your best, etc. And I'll never forget her going to somebody who was a sort of a healer and was giving her tablets. It was costing her about $300 a month, and she didn't have a lot of money. And I asked her to bring them in one day into the clinic, and there was different types of salt, sodium phosphate, potassium, something else, and this is what she was being charged for. So I mean, that's the other side of the coin. If you're taking something that is helping you and maybe hopefully not costing too much, or there's some benefit from it, that's fine. But I thought that was absolutely awful. Now that's the other side of the coin. But to answer your question, I don't know why somebody would have said that. Now, unless there's a specific interaction between whatever one was taking. The other point of that is that may not be a factor in the prognosis on both sides of the water. I don't know. There may be a lot of other factors. Look, as I said, your immune system, who can tell what the differences in immune systems are? I don't know.
Of course. It's just that it really started my mind thinking with your question. When women are diagnosed with ovarian cancer, and there are different groupings in it, is that, in my case, and maybe I'm the only one, is that I didn't even know what questions to ask. I had to put my faith in a surgeon. After all, he was going to be open, sticking his fingers into my inside. So if I didn't trust him, I shouldn't be there. The same when I went on then to a medical oncologist.
That was your perception, is it?
No, I didn't know
right.
what questions to ask.
Right.
It's wonderful that OvaCare is here and we get the chance to meet other people, because I haven't met anybody who had ovarian cancer. And we now know the questions that women should be asking their doctors. And it's not that patients wouldn't trust their doctor, but my own perception is that if you don't trust your doctor, change, because in one sense we're putting our lives into your hands.
Absolutely right. And as I've mentioned, we know we're in a privileged position. I mean, someday I might be on the other side of the fence and I have no idea how I'll react. I absolutely sure. I remember before we had our clinical nurse specialists, who I think most of you who've met with them will agree, will actually ask the questions for you, to you. Very often they'll say, they'll sit down and they'll discuss, what to expect or whatever, and they'll anticipate some of the questions, or even if they don't anticipate the questions that you might ask, they'll say, now, have you thought of X, Y, or Z? I must admit, I used to do that on the bedside at night or on a Saturday morning when I was working in the south, before we had the clinical nurse specialists. Because that's the only time I had in the week to actually sit down with someone and sit in their bedside and have a chat with them. Because the rest of the week it was just madness, running all over the place, doing all the kind of thing, and was very astutely aware of the fact that I wasn't giving time to listen. I didn't have time to listen. I tried as best I could, but I'd sit down at 5 or 6 o'clock or 7 o'clock in the evening and sit down with someone, because I knew that their world has just been completely changed and I need to give them time. Or on a Saturday morning, if I'm doing a ward round, I'd sit down on the bedside and have a chat maybe for 20 minutes, 30 minutes or something like that. But now with the advent of Vicky and Eileen, I think their role has revolutionised what we can do. As in their job is to spend time and do a lot of this. And my perception is, and I'm willing to be corrected if I'm wrong, my perception is that they'll very often bring these things up in front of you, whether you ask them or not. Is that right? Or do you think they still wait for questions? I don't know, because I'm probably downstairs operating while they're sitting bedside upstairs. It's hard to know who wants to ask what is the other thing. I've mentioned already, I tend to try to get an idea of who I'm dealing with very quickly. And one of the great questions that I learned from one of my bosses in Perth in Australia was, what's your understanding of why you're here or why you're seeing me today, even before any diagnosis is made? And I get a very good idea as to what somebody knows or understands about it. But I've got to be very careful that I don't anticipate what I think are going to be her questions, because she may be the type of personality that wants to know little and wants me to talk to her husband or partner more and get it from them, or wants to be very upfront and doesn't want me to talk to their family, etc. So you've got to be careful in trying to anticipate and throwing things out. But I would have hoped that our nurse specialists are pretty good at that.
Sorry, can I just ask, because and I know I'm in a different area, but I feel one with you all, but I had my operation, I left, I see my oncologist, I don't speak to anyone. Now, maybe at the beginning, if there was people there that they spoke to me and I just went over my head, but I don't go and have chats with anybody about anything that I'm doing. I get my treatment, I go home. I speak to the nurses, obviously, in the daycare centre, but unless maybe I could ask for somebody to talk to, but in general, nobody talks.
And is that your choice, or are you disappointed about the fact that it's not offered to you?
About my business, like I'm in the business of trying to make sure that I look after myself as best I can, so I don't seek out anybody. I
Right.
go to get my treatment, but nobody approaches me either. So I was just wondering if the nurses that you're talking about, are they at the beginning, at operation stage, or are they throughout the treatment?
Throughout. This is their full-time job.
So they go and see
Yeah,
the ladies
yeah.
that have the chemo and
Yeah,
stuff.
yeah. I mean,
just
but
wondering, but
the,
that wasn't my question. My question
Yeah.
to you was that, do you think, as we go forward with treatment and surgeries for chemotherapy, and particularly ovarian cancer, that would you like to see like a kind of a more, and I know you're a medical person as well, but a more holistic approach to it, like that includes nutrition, exercise, and complementary therapies
Absolutely
rather than
right.
alternative like those salts?
Absolutely.
Because you hear
Yeah.
weird stuff like mistletoe
yeah,
injections and
yeah.
God knows what, and I really just think
Yeah.
that's all fake.
One of the great advances that Seamus mentioned is something simple like the advent of palliative care referral for a patient who is undergoing treatment, not who has finished and completed all the chemotherapy she can and is now in terminal care, for the want of a better phrase, which is what always palliative care was about, and that's what everybody perceived. If you're a palliative care referral, you're things are in trouble. We now know that the input of palliative care, and I often call them the pain care team or the symptom control team, is very often the way I'll put it to a patient, because there's still perceptions that if I'm being referred to palliative care, I'm like that poor oil spilled duck, and the words that Seamus so eloquently used, but something simple like that has made such an intervention, and it improves survival. You can think, how the hell does it improve survival? It does. So I quite agree with you, the holistic approach. Our problem, I suppose, is that we're just so busy. However, I think our clinical nurse specialists are pretty good at trying to devolve and introduce. I mean, look, we have been part of another charitable organisation who was founded by the husband and sister of one of my patients, who unfortunately passed away quite quickly with an advanced cervical cancer. And we're using that funding for counselling services, for those who feel that they may not be able to afford it, whatever. And we're very much upfront by asking someone, look, do you think you might benefit from X, Y, or Z, rather than being wait to be asked. But any complementary therapies, anything, I mean, when I was working in Australia, there were massage groups. That sounds a bit wrong. There were, all of these, relaxation therapies used to go on in the hospital, on the ground floor in the hospital, while the patients were inpatients only day 2 or day 3 after their surgery. Fantastic, But the problem is people, those with the purse, those with the power to introduce these things, we're always asking for them. And we put our head above the parapet and shut up.
Yeah, no, it's just a case of, for us ladies, what's right and what's wrong. Like, again, the things like massage, I assumed you couldn't have, and then, obviously, I don't know about the rest of the ladies here, but there's support groups online and stuff, and then you have people talking about different things they take, like the vitamins and everything else, and then you read that too much vitamins are bad for you, that you shouldn't be taking them. So, you can be out at sea, even though you're getting treatment and you're well, but you can't think, should I be doing something else? And then you kind of don't know. And, I don't even know
Look, I know Eileen better than Vicky, because Eileen and I have worked together, our oncology nurse, and I know Eileen will give her card to everyone and say, ring me. If there's ever anything you want to know or ask, ring me, and I'll get back to you, etc. And that's a great role for her to have, and that's been a huge advance in our practice. And someone like Eileen knows of all the different things that can be done, etc., etc. And I'm speaking about them, as I said, and I'm assuming that this is what they're doing, because we're rarely early together. But the feedback I get from patients is that I think this is what's happening. Yeah.
The nurses on the oncology ward that I'm attending
Yeah.
now are excellent as well.
Yeah.
I mean, they would tell you about our cows and all
Yes.
the different sports out there,
Yeah.
and ring them in the ward night or day.
I think people who go into this job self-select as those who are probably likely to be good at it and enjoy doing it. Like so many people say, how the hell do you go into that job every week? And you kind of go, you've no idea the amount of satisfaction you get out of doing it. I suppose surgeons self-select because there are certain personalities that just want to fix it now. If I've got a problem, I want to fix it now, personally. Rather than kind of pondering over it for weeks, etc. I love the idea of being able to get in, do something and fix it, and then move on and do something else. But even when it comes to patients who are having a lot of difficulty at the end stage of the disease, one of the most satisfying things can be meeting with them and their family. And even when the goalposts have changed from cure or control to managing symptoms. A lot of the feedback we get are from families and patients who are in a lot of difficulty, and families after somebody may have died will come back and say to you, that made such a difference. There's not a lot you could do, but that whatever you do or whatever you said made such a difference. And enjoyment might be the wrong word, but that is the satisfaction. That's what you go in to do your job for. It's not, it's brilliant, the buzz of doing the surgery, and you might think, God, he's mad. How do you get a buzz out of doing surgery? But I suppose people self-select as to what they want to do, and we do. It's very satisfying doing the surgery, especially when it goes well. But also, it's equally as satisfying as meeting with a family and just sitting down and having a chat and being able to explain things to them, knowing that has probably helped. And I think that's a lot of why you've got oncology nurses and liaison nurses who are probably so good. Now, of course, you'll always meet people who aren't. You know what I mean? Who you kind of go, God, how do they get into this? And the same with medics. I mean, some medics are just terrible at communicating, but they might be a brilliant brain and superb, but they can't talk to you, and they can't explain, or you feel you can't ask questions. So a blend is good, but I think people who go into oncology tend to be the people that you need.
How often do you think your oncologist should see you?
How often should your oncologist see you?
I've only seen mine once.
Is that medical oncologist or surgical oncologist or?
Medical oncologist, yeah. My surgeon is a wonderful surgeon, but every 6 months I see either.
Right.
But I've never seen, I don't want to name it, but I've never seen him. I've seen his nurse liaison,
Right.
who's lovely. But I'm just wondering.
I suppose it depends on how experienced the person seeing you is.
Yes.
Does it always have to be the same person or whatever? Look, in general, we know the first 2 years after treatment are probably the most important with regard to trying to outrule a recurrence. 80% of recurrences will happen within the first 2 years if they're going to happen. That's the intensive surveillance time. Every 3 months we tend to see somebody. As a gynaecologist, I wouldn't expect a medical or radiation oncologist to do a vaginal examination. Now, I know some of the radiation oncologists do, but the medical oncologists don't, because they're not trained gynaecologists. Okay, so that's why it's very important someone sees me or one of my team every 3 months, and then every 6 months from 2 years to 5 years. And I say to my patients, whoever else is seeing you, whenever else, I don't care. I need to examine you myself, or my team needs to do a vaginal examination. So we tend to every 3 months for the first 2 years. Then the risk has come down significantly, so we do it 6 monthly for the next 3 years up to 5 years. Then after that, a lot of them will say, look, I'd like to come back to you once a year because you're the person who knows me best and will examine me probably the most thoroughly. And if I'm reassured by that, great, I'll see you every year. Or sometimes people like to go back to GP. Dr. Coulter, love you to bits, know you for 5 years, but you know what? I'd love to forget about you. And I say, that's fine too. That's fine too. I'm here if there's ever a problem. Your GP can send you back. So that's what we tend to do. I can't speak for individual people's practices, but if they trust their nurse or they trust their registrar to be good and examine you appropriately, it doesn't have to be the one person all the time, you know.
Okay, we're at about 1 o'clock now, which is about half an hour further than we thought we'd get, which is great because you got the chance to ask your questions. I know you're going to stay around with us for lunch, so if you get a chance, you can ask your questions of John, and then there's obviously a Q&A session later on. So now seems like a good time to go for lunch. So lunch is in the restaurant downstairs, and if we could come back for 1:30, if we could, that would be great. Thanks.